What is the most likely diagnosis? Acute cerebellar hemorrhage, acute subdural hemorrhage, frontal subdural empyema, herpes simplex encephalitis, pituitary apoplexy. A 65-year-old woman presents with a 12-hour history of sudden onset gait unsteadiness, vomiting, and headache, followed by increasing drowsiness. What is the most likely diagnosis?
Onset of symptoms is the most crucial parameter and gateway for approach to neurological disease. So let's focus on the rule of thumb with respect to approach to neurology based on onset of symptoms. Onset of symptoms can be grossly divided into hyperacute, acute, subacute, and chronic. Hyperacute onset means within minutes, and this is most commonly encountered in case of hyperacute graft rejection. Hyperacute onset is rarely encountered in case of neurological disease. Acute onset means within hours to day. Acute onset is most commonly seen in case of vascular lesion, most commonly either stroke or intracerebral hemorrhages. Subacute onset means within days to week, which is most commonly seen in case of demyelinating condition like the multiple sclerosis. And chronic onset means within weeks to month, which is most commonly seen in degenerative diseases like Parkinson's disease or Alzheimer's disease, or in case of cerebral neoplasm. So now let's apply this knowledge into our question scenario. This patient has presented with a 12-hour history of sudden onset. So the onset here is 12 hours, indicating acute onset. And acute onset is usually vascular in nature, most likely either stroke or hemorrhages. So if we consider the 5 options here, our answer would be either acute cerebellar hemorrhage or acute subdural hemorrhage, based on the acute onset of symptoms. Vomiting and headache followed by increasing drowsiness is highly suggestive of ICSOL, intracranial space occupying lesion, due to the features of raised ICP. Gait unsteadiness is a cardinal feature of cerebellar lesion. So our unifying diagnosis would be acute cerebellar hemorrhage. This is the CT scan of a 45-year-old hypertensive patient presented with headache, nausea, vomiting, and the inability to walk. This axial CT scan is demonstrating the cerebellar intercerebral hemorrhages, showing areas of high signal intensity or the rounded hyperdense lesion with mild surrounding edema in the left cerebellum. And this high signal intensity rounded hyperdense, that is the whitish color, points towards the underlying acute bleeding or acute hemorrhages. So this is the acute cerebellar hemorrhage. And the immediate management would be surgical decompression and evacuation. So why not the acute subdural hemorrhage? Patient with subdural hemorrhages usually present with fluctuating consciousness, often following a trivial injury, especially in the elderly patient or with history of the chronic alcoholism. So the absence of fluctuating confusion or consciousness, trivial injury, chronic alcoholism, or history of frequent fall is making the acute subdural hemorrhage unlikely. Acute subdural hematoma on CT imaging will show crescentic collection, that is biconcave collection, not limited by the suture lines. Hyperdense or bright, that is the whitish in color compared to the brain. And whenever there is massive subdural hematoma or hemorrhages, we will see the features of mass effect evidenced by midline shifting or herniation. So this is the hyperdense, crescentic or biconcave shaped lesion, not limited by the suture line, pointing towards the acute subdural hematoma. Frontal subdural empyema is always associated with infection. So without features of infection, without features of fever, frontal subdural empyema would be excluded. And frontal subdural empyema usually comes up with the features of seizures, focal neurological deficit, and in some cases with the features of meningism. So next one is the herpes simplex encephalitis. Herpes simplex encephalitis will comes up with the history of gradual decrease in consciousness, short-term memory loss, gait disturbance, expressive dysphagia, MRI showing increased signal intensity in the temporal lobe and cortex. Radiological changes, whether CT scan or MRI showing changes in the temporal lobe, is the cardinal features of herpes simplex encephalitis. And if we go for the lumbar puncture, the CSF will show features of lymphocytosis, being viral infection, and increased CSF protein. And often patient will have the history of business trip to Tokyo. Lumbar puncture and PCR is usually the investigation of choice, and management should be with the IV acyclovir, and mode of action of acyclovir is the DNA polymerase inhibitor. CT scan of head showing temporal lobe changes, think of the herpes simplex encephalitis. And CSF will show lymphocytosis plus elevated protein. And if we go for the MRI, hyperintensity of the affected white matter and cortex in the medial temporal lobes and insular cortex. Viral PCR is the gold standard in the diagnosis of herpes simplex encephalitis, and choice of treatment would be high-dose IV acyclovir to achieve CNS penetration. This is the MRI of a patient with herpes simplex encephalitis, and there is hyperintensity of the affected white matter and cortex in the medial temporal lobe and in the insular cortex. And last one is the pituitary apoplexy, which usually occurs due to hemorrhage into the pituitary gland or hemorrhage into the pituitary adenoma. Patient with pituitary apoplexy usually present with sudden onset of acute severe bilateral headache, hypotension, hyponatremia, low cortisol, often with a history of late or term pregnancy, along with the visual field defect, that's the bitemporal hemianopia, along with tiredness, lethargy, or presyncope, and often associated with the loss of libido. Most of the features here are due to the underlying hypopituitarism. Sudden onset of acute severe headache, especially in the occipital region, explained as thunderclap headache, is a feature of subarachnoid hemorrhage. So, sudden onset of acute severe headache can be seen most commonly in two conditions. One is the subarachnoid hemorrhage, another one is the pituitary apoplexy. To differentiate between the two conditions, we need to look for the blood pressure. Hypotension is most commonly seen in case of pituitary apoplexy, and hypertension is most commonly seen in case of subarachnoid hemorrhage. MRI with or without pituitary function testing is usually the investigation of choice in case of pituitary apoplexy. And in a patient with pituitary apoplexy, due to the pituitary hemorrhage, the most important initial step would be the cortisol replacement, IV hydrocortisone. So the most likely diagnosis is the acute cerebellar hemorrhage. The sudden onset suggests a vascular cause, and the rapid worsening with drowsiness suggests an expanding, space-occupying lesion with rising intracranial pressure, and the risk of herniation. The description is classic for a cerebellar hemorrhage, which by its location in the posterior fossa causes this clinical scenario. It's a neurological emergency requiring rapid identification.